Attendees are in listen-only mode.
Welcome everybody to the newest webinar from SPR. We're happy to have you here, and we're very happy and pleased that we have Dr. Michael J. Lambert from Brigham Young University today. Dr. Lambert is very well known from his research on feedback, as most of you will know, and is also well known from the book that he edits, the Handbook of Psychotherapy and Research, Psychotherapy and Behavioral Change. For those of you that are new here, I'm going to explain very briefly how things go during the webinar. If you want to ask a question to Dr. Lambert, you can either write it in the question window or you can raise your hand. If you see that there's a little hand, if you push that button, you can raise your hand. We see that you have a question, and when there's discussion time, that way we can open up your microphone if you have one, and you can ask the question yourself. So if you don't have a microphone, please use the question window, because that way we can read it for you, and then Dr. Lambert can answer the question. This webinar will take about an hour and a half, and there should be enough time for questions. So let's start. Dr. Lambert, go ahead.
Okay. Thanks, Kim, and Sven. Thanks for organizing this and inviting me to participate. Thanks to all of you who are showing an interest in joining in this. I want to focus on using feedback to improve psychotherapy outcomes and its effects. And I'm happy to entertain questions along the way. And I'll stop occasionally and ask if I'm not getting questions, just to make sure people are understanding what my points are. So I'm just revealing on the first slide here a conflict of interest. That is that I'm not only an academic, but I've entered into a company in order to create software for applying this in routine practice. And so I have a financial investment in that company. So I apologize for having a conflict of interest. But without that conflict of interest, we wouldn't really be able to move this along technologically the way we have. So in our research, program of research, about 12 or 13 years ago, we started wanting to solve a problem. So our research is focused around a specific problem. And that specific problem is that about 5 to 10% of adults and 14 to 25% of children are worse off when they leave our care than when they entered. And so we have a problem with negative effects, or our ability to stop people from worsening if it's got nothing to do with the psychotherapy. And there's a second problem, and that is not only are some patients getting worse, but providers, the clinicians that are offering the services, don't see the negative effects coming. They don't know who's having a negative outcome, and so they're not in a very good position to prevent it from occurring because it's coming as a surprise to them or something they don't predict. And just to give a little larger picture of psychotherapy outcomes, as great as all of our psychological interventions are, in a meta-analysis done by Nathan Hansen, myself, and we just combined 28 studies of different disorders and different psychotherapies. Most of them are cognitive behavioral treatments, but it also includes other interventions. So we're looking across 89 different kinds of treatment in these 28 studies, and we're just calculated the percentage of people who improved, recovered, deteriorated, etc. And we're getting about 2/3 of the patients in clinical trials who are either improving or recovering. So about 60% are recovering, returning to a normal state of functioning, and another 10% are improving but not recovering. And that leaves about 30% who are either not responding or who are outright worsening. And these individuals in these clinical trials are getting, they're very carefully selected individuals, and in some ways you could say they're ideal candidates to show a treatment effect. And the number of sessions is set at 12 or 14, depending on the study. Sometimes they're up to 20 sessions. And the patients are told at the beginning that they're expected to participate for the length of the treatment, and the researchers do what they can to keep dropout rates low, and they replace patients if they drop out very early. So this is probably, you could say, this might be the best we can do, and it's pretty doggone good when you consider that many people are responding reliably to our treatments. In routine care in the United States, the situation's much different. Looking across 6,000 patients across the whole US of A, we're getting about only 14% of patients who recover and about 21% who improve. So we're getting about 1/3 of the patients, and the average number of sessions is only 4.3, and this includes or excludes patients that come in for a single session and leave. So this is the mean number of sessions when people actually come for, at least for a second session. And as I mentioned, in child outcome in routine care, we're looking at deterioration rates that are much, much higher, with even in the most serious settings, publicly funded mental health care at community mental health centers in the U.S., we're getting 1/4 of the kids who actually worsen during treatment. So this is the problem, good news and bad news. And so if we're going to solve this problem, we're going to look at the red group and the yellow group in this slide, those who don't change one way or the other and those who deteriorate. And from our point of view, from our research perspective, we're going to leave the green group alone. That's 50% of people around. We just are not, this intervention that we've devised is not for these individuals. It's for the yellow and red group. So we're looking for treatment failures and treatment non-responders. And then we wouldn't embark on this line of research if clinicians could do the job of recognizing these individuals in real time before they left treatment. But they don't do it, and they seem unable to do it even if they're asked to do it. So Corrine Hannon did a study in which we broke into practice in the clinic, and we asked 40 therapists to answer 2 questions at the end of each session. One was a predictive question. Do you think this is one of the 8% of people that will leave treatment deteriorated? So we were asking them to forecast the future, and they knew the base rate was about 8%. So could they figure out who those people were? And then the second question was, at this session of care, is this patient worse off, functioning worse than they were at the onset of your treatment with them? So during that 3-week period, 550 clients came in for sessions of treatment. Some had 3, some had 2, some had 1 over that 3-week period. And the therapists, 20 of whom were licensed psychologists with 10 years experience, and 20 of whom were trainees seeing their first cases, to interns who'd had quite a bit of experience. So they only identified 3 cases out of 550 who they thought would leave treatment worse off. And in fact, 40 had a negative outcome. And of the 3 guesses they made, they were correct only once. And the correct identification was a trainee. So the professional staff did not identify a single case of the 40 that went on to have a negative outcome. But our
Mike?
statistical, yes.
We have a raised hand, so perhaps something is not clear, and should I open that microphone?
Sure. Yeah, sure.
Okay, Marcela Paz Gonzalez, go ahead. Marcela? Can you hear us? We can hear you, I think. Go ahead and talk. Marcela, can you hear us? All right, let's continue. I'll just close up the microphone. Go ahead.
So our statistical methods that we've developed for predicting treatment failure, we were able to identify 85% of those who went on to have a negative outcome. So the point here is that clinicians aren't able to do it even when they're asked to do it, and even when they're in a contest with licensed professionals compared to interns and practicum students compared to statistical algorithms. So there's a problem specifically with negative effects. And we cannot solve this problem if we don't know who's on a road to deterioration. So just as another example, Derek Hatfield tried to see if patients deteriorating was entered into case notes of the therapist. So he found a group of patients who were worsening by about 3/4 of a standard deviation, so they were getting significantly worse. And he found in case notes following the sessions of those patients' deterioration that the therapist only entered a remark about that deterioration 20% of the time. And then he looked at a group of patients who got 30 points worse. So this is a substantial worsening. This is like going from the normal range for an adjustment disorder into disturbance that's similar to inpatient disturbance. Even there, they were only mentioning deterioration 1/3 of the time. So if we're noticing that, we're recognizing only 20 to 30% of the cases. The vast majority of people who are worsening during the course of therapy, that worsening is not noted in the case notes. So if you think about what we have to offer therapists as scientists and researchers, one of the things we can offer therapists who are in routine care or even clinical trials, is the ability to identify a subset of patients who are not progressing and in fact getting worse. And we believe that providing that information to therapists in real time while they're still seeing their patient is a kind of feedback that's likely to help patients in a timely manner before they depart from treatment. So in order to do that, we developed a scale called the OQ45 that looks at symptoms mainly of anxiety and depression, such as I feel hopeless about the future, rated on a 5-point scale and looking back over the last week of the person's life. So over this last week, I felt hopeless about the future almost all the time at one extreme to never at the other extreme. Then the second thing we define as outcome is interpersonal problems. So we're not just interested in anxiety and depression, but we're interested in how people are getting along with others. So an example item is I feel lonely. And then the third area is social role functioning, which has to do with the fact that if you're younger, you have a job to do, which is to go to school and be successful. And if you're an adult, it's to have paid employment where you go to work and you get your job done. And if you're not in the paid employment field, but you're a homemaker, or even if you're retired, there are certain roles that you still can be expected to perform, and if you're not performing them, then society suffers in all the ways possible. And then the fourth area we were interested in was well-being, so positive mental health. Does intervention increase sense of well-being? So all through this presentation, when I talk about outcome, I'm talking about self-reported outcome as measured by a 45-item scale that reflects functioning over the prior week. And so I guess we could call that measured outcome. The patient may have other opinions about the effects of treatment, and therapists certainly have other opinions. But we've limited what we've done more or less to measured outcome through self-report. So then once you start measuring outcome, then what we try to do is monitor patient treatment response on a weekly basis. So at each session, the person comes in for help. If they're an adult, they fill out a self-report form. If they're an adolescent, they fill out self-report. And if they're an adolescent or child, we have a parent report. So we're tracking kids as well as adults, although most of what I'll talk about is about adults. And then we try to deliver this mental health vital sign, or this self-reported mental health status, to clinicians, and we're able to get it through them through our software and computer system. We can get it to the clinician in about 2 seconds after the patient completes the measure. So the equivalent would be thinking of it as like blood pressure in physical health care. Now we've got a mental health lab test where we're essentially asking clinicians not to practice without measured mental health. So to more formally ask clients how they're doing with these 45 questions. And then what's most critical in our work is alerting therapists to poor treatment response. So we're essentially devised a method of telling clinicians, or predicting and giving clinicians predictive information, that a particular patient is in danger of leaving treatment deteriorated unless something changes. So I think I should take a break here and see what kind of questions people have. Are you out there?
Hi, Mike. I'm out here,
Hi.
and there's no
Okay.
questions at the moment. We just had a good question, but I took the liberty of answering that. Somebody asked whether the clinicians remain reliant on the feedback. So if you take it away, or basically, are they learning from the feedback?
Mm-hmm. So we don't find that they're learning from the feedback.
Mm-hmm.
Just as doctors don't learn how to detect somebody's blood pressure, they have to take it. You have to measure it. You can't guess it.
All right. So we do have a new question from, oh, I hope I pronounced this right, Saurong Su. Go ahead. Let's see. Yes, I've opened up your microphone. Hello? Okay, so we have a question here, and it says, I want to ask if the feedback from only the patients is worth to trust.
Okay. So I'll just repeat the question. Can we really trust patients' self-report
Yes.
of their mental health?
Mm-hmm.
And my answer to that would be, it would be ideal if we were calibrating or quantifying people's mental health from the point of view of not only their self-report on a questionnaire like the one we developed, but if we also had clinicians rate it, and if we had people in their life rate their mental health, like their spouse or their roommate, and it would be nice to measure their physiology, and it would be really great if we measured their performance at work, for example, or at school. So there are a lot of sources that we could rely on, and it would be ideal to rely on them all. But for practical purposes, we can't expect clinicians to spend the time that they're devoting to treating people to doing an assessment every week. And in order for the clinician to be aware of everything that's happening with the patient, the clinician would have to ask the patient 45 questions to be specific if they're going to get the same information we can gather from a patient in 5 minutes.
Okay, so sorry.
It's highly impractical to use other sources other than the patient. And even if you used other sources like expert interviews, they're relying essentially on patient self-report. They're just not gathering it through a questionnaire. They're asking the person, and the person's giving them some information. So self-report's the most practical, but we will find that these measures, like the one we use, can be easily distorted if a person wants to. But most people who are in treatment are in pain, and they have very little reason to not cooperate and give honest answers on the self-report measure, especially if they realize that that information is going to be used by a clinician to help them. What would be the point of coming to treatment if what you're going to do is lie to the clinician or distort things to the clinician. So undoubtedly that happens, but we think it's an exception to the rule, not the rule.
Okay, thank you. We have a new question.
Ask if that's a satisfying answer or if it's better to
Yeah,
have
I
a little
asked.
debate about it.
I did ask it, and this person says yes, I think partly. So let's see if there's a follow-up question. It's not coming straight away. So in the meantime, I'm going to ask you another question from Nora Hinojosa, from Monterrey, Mexico, and she asks, which is the parent report scale used in children? Until what age does the parent report?
We call the child measure the Youth Outcome Questionnaire, and we have parents report up till people are 18. So from people 4 to 18, we get a parent report. But we start giving children at the age of 12 to 18 a self-report measure as well. So we usually try to collect both the adolescent's rating of themselves and the parent's rating of the adolescent.
Thank you.
And there's also a form for a caseworker. So if it's residential care or inpatient care, there's a form that can be filled out by the treating person or the person in charge. If the parent's, for example, not seeing the kid because they're in a hospital, then it's hard to get a weekly rating.
Mm-hmm. Okay, so we have two more questions. One is from Stephen Buller. I'm going to open up the microphone right now. Go ahead, Stephen.
Hello, Michael. It's Stephen Buller. Hello. Just do your clinicians know what to do if they get alerts that patients aren't improving or are deteriorating? Do they actually know what to do with the alerts?
At the bottom of the feedback that we give them, I'll show you a screen with the feedback that they get. We say a little bit about what they might consider doing, but it appears that if you alert clinicians, they figure out what to do to an extent. And so the problem is partially solved by simply alerting them and saying this person's headed for a negative outcome. And we'll say, consider the treatment plan, reconsider the treatment plan. But then in 5 of our studies, we've gone beyond that and given them a structure for problem solving that's even more helpful than just giving them alerts. So the problem seems to be that they're not alerted, and they seem to be able to solve the problem to an extent if they just know.
Okay, so Stephen, does that answer your question?
I could follow it up if you've got a moment.
Sure, followed up as far as I'm concerned.
Right. We're doing sessional outcome measures too here in Derby in the UK, and my question was based on the fact that we're having trouble getting our clinicians to respond to the alerts they're getting, or respond in a way that enables them to get the improvement in the interventions they're using. Without stepping right out of therapeutic boundaries and referring their patients on to other clinicians. So we're finding it hard for that to get our clinicians to respond within the therapeutic frame to get the improvements or the changes that are necessary produce the improvements to stop deterioration or to move recovery forward? Do you have an idea about that, please?
I think the first question is, do they see the feedback? Do they look at the feedback?
Oh, yes.
And then the second question would be, do they think that the scientific methods behind the alert can do the job better than they can?
Okay. So that's their confidence. Yeah. So that's their confidence in the feedback they're getting. In other words, is that right?
Yes.
Yeah.
Yes,
okay.
I think so.
Yeah.
Now,
okay.
Now we find clinicians don't think they need help.
Yeah. Okay.
And in a survey we did of clinicians, their perception is that 85% of their patients are getting better.
Yeah.
Which is much better than clinical trials and 10 times better than routine care.
Mm.
So measured outcomes through a scale show much less progress when patients are reporting how lonely they feel, how many fights they're having, how sad they are, if they're having headaches, if they're sleeping. So when you ask patients a lot of questions about their functioning and you see how much they change over time, it's not anywhere near 85%. So that's part of the problem, is clinicians are very happy with themselves and with the progress their patients make compared to measured outcomes.
Yeah.
And then the second part of that is that each individual clinician, 90% of us clinicians believe we're in the top 25th percentile of all clinicians.
Yeah.
And no clinicians that answered our survey thought they were below average as a clinician.
Yeah.
So what you see is clinicians are very confident in their ability to help people,
Yeah.
and they feel they're better than others,
Yeah.
their peers. So what we've got is a kind of a little bit of a clinician delusion problem,
Mm-hmm.
and this makes them quite hesitant to trust what we're delivering to them.
Yeah.
And I think part of the solution is, do clinicians care at all about the scientific evidence that suggests our computer algorithms can identify 100% of people who go on sometime later to deteriorate,
Okay.
and they can't identify a single one.
Mm-hmm.
That information, I mean, if they can believe it, would make them more keen. And we find clinicians able to solve the problem if they get the alert.
Yeah.
So I think we need to move on, and we'll keep the questions that are still there for later on. Mike, go ahead.
Okay.
Go ahead. Stephen, I'm going to close up your microphone again.
Yes, thank you, Michael.
You're welcome. So just in terms of how we're predicting treatment failure, so I'm showing you a graph, and on the left side it has scores on our test, the OQ45, and on the horizontal axis at the bottom it has sessions of psychotherapy. And so what we did is we monitored with our questionnaire, giving it every week, to people who are in psychotherapy in the United States, all across the country. And we collected data on 11,000 patients. So this is data where we weren't giving feedback to clinicians. We were simply collecting weekly reports of client functioning with the OQ45. And then we essentially developed an expected treatment response over sessions of psychotherapy with starting at different levels of disturbance. So we have 50 graphs like this. This is the graph for anybody that has a score of 97 or 98. So that's where they started treatment, and that's quite disturbed. The average person in the U.S. and some other places is getting a score of 45. That's where they start. And we define normal functioning as a score of 63 or less, and the score of 97 is more than 2 standard deviations above the mean of normal functioning. So this is quite disturbed. This would be quite typical in the United States of somebody that was an inpatient. And you don't get into inpatient here in the U.S. without being pretty disturbed. And so the black line in the middle is just progress over time. And we predict treatment failure by whether you go off track from that expected treatment response. So we set the upper boundary at red is actually the upper 10% of people. So if you were ever to get a score that hit that red mark, that would be a red alert, and at that particular session of care, only 10% of people are ever that far off from the black line. So the road to recovery is improvement. The road to deterioration is negative change. And all that's calibrated against where you begin treatment. So what predicts treatment failure, what clinicians don't use to predict treatment failure is negative change, because clinicians can't calculate how much negative change is a problem and how much negative change is a ordinary fluctuation in functioning from week to week. So it's perfectly all right for people to fluctuate, to improve and get worse, but when they start to get so far off from recovery that they hit the yellow or red line, then they're an alert case. So when we test this to see if we can actually identify deteriorators, I think our first study we had 500 clients, and we were able to identify 100% of the deteriorators. So it actually picks up people who deteriorate, but we overpredict deterioration. So what clinicians do is they never predict. What we do is overpredict. So we give false alarms. And that's not such a bad thing, because what it starts to do is cut into the non-responders. So you may not actually be a deteriorator, but you're very likely to be a non-responder if you're not a deteriorator. So again, what we're alerting clinicians to is, in some cases, a false alarm, but a non-responder at the end of treatment. So we don't have the brains that we can do this. This is why clinicians can't learn anything from the feedback, because they can't calculate the numbers. How much worse does a person have to be if they start at 80 and get 10 points worse, or start at 65 and get 15 points worse or 30 points worse? We just can't calculate these things, but a computer can do it. So this is where, in clinical practice, I think that clinicians should let science in, because science can do some jobs, and one of the jobs they can do is make predictions more accurately than clinicians, especially when clinicians need to distort patient treatment response in order to keep themselves committed and hardworking, and we can't afford to get discouraged. So our minds help us externalize it, for example, or say it's not a big deal, or say it's not my fault, it's a bad patient. So I don't know if anybody wants to ask about this predictive method, because this is the scientific part of it. This is
I have one question from Sandra Rothman that says, can Dr. Lambert give some examples of recommendations to clinicians where there has been an alert?
Yeah. Maybe, though, I should hold off on that, and because I've got a few slides that will illustrate that.
Okay. So let's just continue then.
Okay. So in order to implement this in routine care, you've got to have some method of inputting the client's answers. So this is just a handheld device that we put it on from our software called the OQ Analyst. But it can be done on an iPad or a computer kiosk. It can even be done by hard copy. And you can see the question there, I get along well with others. And then the client is asked to mark never, rarely, sometimes, frequently, almost always. And that's in reference to this last week. So I get along well with others during this last week, almost always would be the most positive statement. So once you've answered the 45 questions, then the software scores that and it applies the predictive algorithms to it. And then what you end up is a report. And on the top right-hand corner of this report is an alert status. And there are 4 or 5 possible alert statuses. A white status would mean the patient's return to a state of normal functioning. A green status would mean the patient is still in the disturbed range, but they're responding to the treatment, but the treatment needs to continue. And the treatment, as it's going, will probably result in a good outcome. And then a yellow status is a warning and a caution that maybe the treatment's not having its intended effect. And then the one you're seeing on the screen is red status, so this means that the patient's quite far off from what we expect. And so this only takes a clinician a couple of seconds to look over to the alert status and see if it's red or white or green. And we actually find that the color matters. And so what makes feedback work is if it's novel information and if it's visual. And colors are quite a visual thing that skips the cortex and goes to the amygdala. And we hope it goes to the amygdala because we don't particularly want clinicians adding up numbers. What we want clinicians to do is be alarmed. And so the color is quite effective at doing that. Then additional data on this is some critical items. So, for example, item 8 is a question about suicide. I have thoughts of ending my life. So during this last week, this patient reports having thoughts of ending her life sometimes during the last week. So that pops up in red, and it might signal to the clinician that they need to pursue what kind of suicidal thoughts. And then there's some substance abuse items. It's another thing where clinicians may not be asking on a weekly basis, things that are a bit alarming about their substance abuse. And then on the bottom part of this report is a graph. And so if you were looking at this on a computer screen, the top and bottom would be just one page. So it's not split into two pages the way I'm showing it. And what this graph shows is scores on the OQ45 on the vertical axis, and on the horizontal axis it's showing specific sessions. So this particular patient has 5 OQ45 scores, an intake score plus. It's taken, the patient comes in 10 minutes before the session. So the second one that's shown here would have been taken before the patient had the second session of treatment. And there's a black line, and that's the expected treatment response. And there's an orange line, horizontal line, that's normal functioning. So we want this patient to dip below the orange line if possible. And then the blue line is the actual scores that the client gave. And so they started with a score of 89. They got a little bit better and were a green signal case. They got worsened at the third measurement point and went off track so far as to get a yellow alarm. They get a red alarm at the fourth and a red alarm at the fifth session. So they've signaled already 3 times right from the following the second session of treatment. And then the message at the bottom essentially says the patient's is deviating from an expected response to treatment, and they're not on track to realize a gain from treatment. They may drop out of treatment prematurely or have a negative outcome. So you need to review the case and identify reasons for their poor progress. And then we also suggest that there are certain things that might need to be inquired about, like the therapeutic alliance, and that it's especially important to continue monitoring this person because they're at risk for treatment failure. So the intervention is quite brief. It's essentially 5 minutes of the patient's time and a few seconds of the therapist's time. That's the extent of the intervention. So then the question came up, what should you do about these failing cases? So we noticed giving feedback to therapists that their patient was off track was having a good benefit for the patient, but still many of the patients weren't returning to normal functioning. So we developed a second measure that we call the ASC, and that measure is the assessment for signal clients. And so essentially what the manual says is, what do you do if the client signals red or yellow? You ask the client to take the assessment for signal clients, the ASC, and then you get a report from the software, and it gives you a decision tree to organize problem solving for this particular case, and also a list of possible interventions that might be helpful to the client. So now we're really starting to help the clinician problem solve. So this ASC is a 40-item self-report instrument that asks 12 questions about how the client perceives their relationship with you, the therapist. It asks questions about how motivated the client feels. It asks questions about the client's social support network, and it asks clients about any recent life events. And then the report that you get to see based on this, the way they respond to these 40 items, is we highlight any items in red that call for action. So you glance at this report and you start to see there are certain items that pop up that are lower than other patients' ratings. So I'll give you some examples. One of the items from the Therapeutic Alliance scale is my therapist seemed glad to see me. So the patient rates that, and we've given that to hundreds of patients, so we know what an average response is, and we know what a low response is. So any response a patient gives that's below the mean of all patients by a standard deviation comes up in the therapist report red. And then the therapist needs to reflect on why this particular patient is saying that they're not very glad to see them. So obviously, if you're trying to solve a problem of a patient feeling that you're not happy to see them, you could smile, for example. It's just that simple and silly, is you're getting some feedback that you're not warm enough or smiling enough, or you seem preoccupied, or you're just doing your job, but the patient brings no joy into your life. And then you could reflect on what that's about. Is it, that you are tired, or that there's something about them that they're just really hard to work with and you don't enjoy it, da-da-da-da-da. And so these are the kind of items that start to give therapists some ideas about what could be wrong in therapy. It could be an alliance problem, and these first two problems are about the therapeutic bond not being sufficient. And the therapeutic bond is another area where therapists are not very aware of patients' reactions to them when they're negative. So we're not appreciative of the fact that when clients have a negative reaction to us, they tend to hide it, and they successfully hide it, so that they keep that secret because it's embarrassing to them to have a confrontation with us when their feelings get hurt, or when they feel mistreated, or disrespected, or misunderstood. So we're just starting to try to bring information to the therapist about the alliance. So another area we're interested in is social support. So now we're not interested in the client's relationship with the therapist, we're interested in their friendships, and to the degree to which they can count on others if something goes wrong, so that they have a social support network. So if a patient's getting worse and they're answering very many questions negatively about their social support network, then the therapist is led to consider interventions that might change the quality of these social supports. For example, a therapist might decide that the patient has very few or no positive friendships at all, and add on group therapy to the individual therapy, or add on a social support group to the psychotherapy, because that will give a person a kind of temporary social support until they can build a better network. So I hope this is making sense. This might be a time to pause to see if people understand how we're attempting to guide therapists towards solutions.
Let's just wait if some questions are coming up. I do have two questions from earlier on. Maybe I can start by asking them. Okay, I have a question from Tim Guimond or Guimond. And he says, when we think of vital signs, we often find that we can focus in on one or two of importance. For instance, temperature for febrile illness, blood pressure for hypertension, etc. Wouldn't it also make sense then to focus down on a smaller subset of questions?
Yes, and so we do, in the software, we do allow a clinician to look at the way the patient answered every single question. And so, but that takes a little bit of time for the therapist to do that. So right now we don't give feedback about which symptoms are getting worse since the first intake, and this would probably be very helpful. Well, we haven't gone that far, but it makes sense to me.
Unmuted.
Well, thank you. There's another question from Ignacio Echebarne, and I think it's about the previously a topic we also already talked about whether we can trust our patients to provide reliable answers on a self-report questionnaire.
Muted.
And he says, I don't think it's necessary to think in terms of deception, but it's very common to find in anxious patients that they are unable to recognize gains, and this would seem to sustain their catastrophic thinking and hence their suffering. Wouldn't it be better to use an inventory that also has a fidelity scale that assesses whether patients are telling the truth?
Yes, we've definitely considered the usefulness of that, but unfortunately the scales that are existing that do a fair job of that are quite long, even longer than the symptom questionnaire itself. So what you start to get into is too much time to be practical to use in routine care. As our opinion is, we can expect patients, and they don't mind taking a 5-minute questionnaire, but if you start expanding it beyond that, you're not going to be able to do it weekly. So there's absolutely a problem with not being able to trust self-report perfectly or even 100% of the time. But for most people, it works most of the time. So it would be a shame to throw out the methodology because it doesn't work with every case. So the cases where it notoriously is difficult is with substance abusers who are referred in by their employer, and they're made to come in by their employer, or kids that are forced to come into therapy by a parent and who think if they deny things they can get out of psychotherapy. in substance abuse, there's a tendency for people to not admit to it if they think the information is going to be used against them somehow. So I think for me, I would say once we're doing self-report, then we can add other methods on. But to wait till we have a method that can't be distorted is to never get around to doing it.
Okay, thank you, Mike. I have another question from Kristin Bergman-Warnecke. Her question is, do you have an example of an outpatient clinic which compares numbers of deteriorators before and after this introduction of the feedback system, which illustrates how well the system can be used to cut down numbers of deteriorators in a reality check, taking into account that some therapists may use the feedback better than others?
The answer is yes to both of those. So we have some very good data coming now from eight clinical trials where we randomly assign people to get feedback and no feedback. And we also are starting to get some evidence about differences in therapists' ability to use the feedback. And I'll show at least how much impact, how much we can lower deterioration rates in a slide that's upcoming. So very solid evidence.
All right, well, thank you. Let's continue then. I mean, for you to continue, sorry.
Okay, all right. So what the way we try to help clinicians organize problem solving is we ask them to pay attention first to the therapeutic relationship. Many examples of deterioration come from subtle rejections from the therapist, and we need to formally ask in a systematic way about the relationship in a questionnaire. And then motivation is quite important because if people don't think the therapy is going to help them and is helping them, they're not likely to have a positive outcome. And social supports perhaps are the most important area for deteriorating patients, that something bad has happened in their network of support that's left them in trouble or panicked or abandoned and unable to cope. And then there are certain life events that are critical. Most of them are in the category of losses. So the death of a close other, a divorce, the ending of a relationship through a fight, and then other life events that seem to be particularly important are physical, and especially if they involve pain. So if the person has a chronic illness with pain, psychological deterioration is often linked to not being able to manage and handle physical illness. And then the last thing we do in the organizing therapists to solve problems is asking them if they need to reconsider the diagnosis and make a referral to a psychiatrist or an MD for medication, because they may need to be on medication. So we just ask therapists to consider, is it time to refer this person for medication? So we've relied heavily on the work of Safran and Murrens on repairing alliance interventions. So we give a lot of, when it comes to suggestions to clinicians, we just remind them of some of the tactics that are helpful for repairing a ruptured alliance. So, for example, providing another rationale for your techniques and actions, talking more about the relationship, spending more time exploring client feelings, client negative feelings. So these are highlighted in the software, and then the therapist has to read them and consider them and think about it. So we're just trying to touch off possible things to do. If it was in social support, we might say consider referral for a support group, or consider referral for a social skills training group, or consider bringing in a spouse, or consider bringing in the family, etc. So there we're asking the therapist to do a little bit more social engineering. We find it takes a clinician about 18 seconds on their own computer to look up the progress report or the assessment for signal client report. So taking clinician time, this is meant to be extremely time-saving to clinicians and hardly uses any of their time, whereas it probably uses 5 to 10 minutes of client time. So our program of research in terms of does any of this help clients, we published our first study in 2001 and followed with a replication in 2002. And then in 2003, we started to use the clinical support tool to see if we could strengthen the effects of treatment. And published a study in a different treatment setting in 2005, and then replicated that in 2007 and 2008. And now we have done another replication of the Hawkins study, and we've done a study now in an inpatient eating disorders clinic. And one that I haven't listed here is a study with substance abusers that's published this year, 2012, by Kutz Kustoff, myself, and some other co-authors. So we've got a lot of empirical support, and we've got some pretty good estimates of the size of the treatment effect from these 6 clinical trials. And the most unique aspects of these clinical trials that include random assignment is that the random assignment is within therapists. So any one therapist in a study, half their clients will give them feedback, and half their clients they'll practice as usual without feedback. So when you find a difference, if any, between the two groups, the feedback group and the no feedback group, you know it isn't likely to be due to the therapist, because it's the same therapist offering both treatments. So in terms of results, looking at it graphically, we have OQ total scores on the vertical axis, and we have change from pre-treatment to post-treatment on the horizontal axis. And if you look at the bottom 2 lines, those are people that never go off track. All through their therapy, they either got green signals or they got white signals. They never got yellow or red. So those are patients we call on track. And this is about 70% of patients. So the typical response to therapy is to be on track. And what we find is that feedback doesn't have a very big effect if you're on track. So it doesn't help to tell the therapist the patient is responding as expected. That doesn't improve patient outcome. patients might like to be told that, and it might be, you know, a pleasant experience to be given that kind of feedback, but it doesn't reduce their symptomatology. On the upper side, the upper red line is the effects of the way most clinicians practice now, which is without warning alarms and problem-solving tools. And what you can see at pretest is these people are quite disturbed compared to on-track cases. They get worse, and that's the middle red dot. And then they leave treatment slightly worse off as a group than they entered. So they do show some improvement from the first time they have an alarm, but as a group, they come and go from therapy without having a benefit from treatment. So this is what we're trying to change. And then the yellow line represents the feedback condition where we give alerts and alarms to clinicians. And the middle point there is the score on the OQ45 at that point in time when the person got the first red or yellow alert. And then you can see that when they leave treatment, they're much better off than the treatment as usual. And that effect size is about 0.40. So it's a relatively large effect size. And then the third green line is when the clinicians use the clinical support tools. And you can see now at the post-test on the green line, if normal functioning is defined as a score of 63, these people as a group have almost reached it. So they're, as a group, really close to normal functioning. And if you look at the difference between those top red and green lines, that effect size is about 0.70. So it's a dramatic effect from giving alarms and clinical support tools to these therapists who, I would remind you, are not exactly gung-ho about all this. They're not exactly enthusiasts. They're just good sports who are participating in research studies. They're not people that we've trained who are people that have come to like practice this way in these studies because that's the way they practice. They're practicing this way because they're willing to be in the research project and try something new. So if you turn that into percentages, then in treatment as usual with these not on track cases, so this is the base rate. The base rate recovery improvement is 20%, 21%. And the base rate deterioration rate among these people that go off track is 20%, 21%. When we give therapists alarms, the recovered improved rate goes up to 35%, and the deterioration rate drops to 13%. And when we give therapists problem-solving tools, the recovered improved rate goes up to 50%, and the negative change deterioration rate goes down to about 6%. So from 21 to 6. And recalling that this is a replicated finding, so this is not one study. The 21% versus 6% is data from 3 studies all combined into this graph. So it's a pretty substantial finding I don't think there's an intervention out there that has that kind of data to show how much it helps. So with these off-track cases that make up about 20 to 30% of our clients, we can choose to have a recovery rate of 21% with 21 deteriorating, or we can choose to have half the patients getting better and only 6% getting worse. To me, it seems like a substantial effect on patients, and one that shouldn't be ignored, but is surprisingly slow to catch on, given that our first study was published in 2001. It's quite surprising, really, that people aren't rushing to do this and insisting that they do this. I think the fact that that hasn't happened, that it's only starting to happen, is a testimony to clinicians' low opinion of research. So maybe we could field some questions at this point in time.
Yes, Mike, we have a question from Nora Sloan, who says, I'm interested in monitoring client progress in time-limited group therapy. Do you recommend using this type of signal system to track client progress in group therapy? And if so, what modification, if any, to the feedback system would be needed to adequately study the effects of client feedback in group therapy?
Yes, I think this methodology is especially useful in group psychotherapy, but we've never done a study just limiting to group. So I can't say how much it helps patients in group psychotherapy, but there's every reason to think it would be even better in group, because a group leader with, say, 8 patients in a group has no way of knowing how patients are functioning over the last week, and there's every opportunity for clients in group psychotherapy to hide a bit. So if they don't volunteer much and they choose to be fairly passive, it's not likely that it'll come into attention. And so if you're a group psychotherapist and you had 8 reports to look at, you could quickly look for red and yellow cases within the group and make sure that those people get some floor time and some focus in the group. And I don't think the measure would need to be modified at all, because we're just measuring anxiety, depression, interpersonal relationships, and social well functioning. So it's geared at individuals, and it doesn't matter what the treatment method. It would be just as appropriate to use for medication-only intervention, as well as psychotherapy, as well as group therapy. So I think it's perfect. And group therapists love to have it.
Nora says, great information, thank you. There's another question from Nicholas Forant, who says, hello Michael, this is impressive stuff. 2 questions. It seems that the method has high sensitivity for deterioration. Have you made any attempt to reduce the false positive rates, or done any work to try to understand the difference between your true and false positives? In other words, do any patients or therapy characteristics predict temporary versus permanent deterioration? And second, what do you think are the main barriers to implementing your system other than client resistance?
Yeah, since the predictive methods we've used, and there are others that we've tried out that are not built into the software, but actually in the software there's two different alarm systems that are functioning that were developed by completely different methods. And the person using the software can toggle back and forth between the two predictive methods. One's based more on clinical opinion about what would be alarming, what kind of change would be in alarming, and the other one's the statistical method that I showed you. But they have real similar predictive abilities. Both make about the same number of false positives. And I really don't feel any need to improve it because we can get about 100% of those who deteriorate, so we're not missing any or very few. And it's not like identifying somebody as not on track is going to lead to surgery or something potentially highly harmful. So not being perfectly accurate is not a problem because there's a substantial number of non-responders whose outcomes we want to improve. So with the error rate that we're getting right now, we're simply cutting into the lowest level of non-responders. So I don't feel much ambition to improve it. I guess it would always be nice, but the kind of false alarms we're getting are really not a problem. And then let's see, the second question was?
The second question was, what do you think are the main barriers to implementing your system other than clinician resistance? For example, cost, infrastructure to support it, etc.
I think the main barrier is clinician resistance. Anytime you open up the privacy of a therapy relationship to something that gets measured and embedded into an information system, this is very, very threatening to clinicians. If in our practices we're 85% successful, then measuring outcomes can only diminish success. And I think clinicians intuitively would just rather make up their own minds about whether and how successful they are. So I think we have to overcome our fear of evaluation and our fear of, I'd say, being average in order to implement this. But then I think you've got to have administrative support. Somebody has to be a champion of this method because it costs some money. For an individual provider, it would probably cost $200 a year. Plus, you'd probably have to have some device to input the data, so you'd have to buy an iPad or a handheld device, or you'd have to have an office computer available, you know, a kiosk. So if you don't have one, you'd have to, you know, purchase one. That can cost a couple $100. And then, you know, it can be set up remotely. It can be even set up for people to complete the measure at home online, so you don't even have to do it in your office. It can be done before people come, although lots of people don't get around to it, and so you still probably have quite a few you have to do in your office. So I think that administrators are extremely excited about having the data because they have to show that they have to be accountable, and they need to monitor, or it's in their best interest if they have some data about how effective they are. So I don't think administrators resist it because it's information they can use. And patients don't resist it. It's rare for a patient to resist it if it's offered to them in a you know, as a mental health vital sign that will help the clinician be more effective at treating them, then clients are all on board. And they usually, if you're giving them graphs themselves, they're rating the feedback like at 8 on a 10-point scale, with 10 being completely happy and 8 being very, very happy. So it's not client resistance. I'm afraid we as clinicians have to take most of the responsibility. And personally, I think a huge amount of it is fear-based. How you overcome that fear is, I think, that if you can get people to try it, at the very least, they love the graphs. But there's no harm in having a graph of your patient's rating of their mental health from week to week over the time you've seen them. And clinicians really like the graphs, and if for some reason the computer goes down, clinicians want it up and running because they want that information. So getting people to do it for a while is probably the key element for getting it to take off.
All right, so thank you, Mike, for this answer. We have a question from Tim Guymont or Guimont, and I'm going to open up the microphone right now. Go ahead,
Okay.
Tim.
Hi, Michael. Thank you so
Hi,
much.
Tim.
It's been very interesting, and I had a question then, something that you alluded to earlier about the potential that there may be some therapists who are somehow more responsive and others who are less responsive to the feedback. I just wondered if you could describe a bit about that, what's known. Are there some therapists who somehow we could predict that given the feedback they're more likely to adapt and respond in a way that's helpful?
Yeah, we don't know very much about that, truthfully.
Okay.
But in one of our recent studies, we didn't get very big effect sizes, and we'd already done a study in that clinic, and we were quite surprised that the treatment wasn't more effective in that clinic. And it was a clinic that had just 6 therapists. And when we looked at the data more closely, 3 of the therapists had no effect whatever from getting the feedback. And 3 of the therapists had the usual effect size. And so what we believe is that the therapists weren't doing it.
I see.
And so the first thing that we learned from that study is there needs to be a method for making sure clinicians are doing it. And nowadays, the software will tell us if the clinicians opened the clinician report.
Okay.
It won't tell us if they did anything about off-track cases, but it will tell us they at least saw the report. So in our early studies, we handed out a questionnaire to the therapists where we got feedback about whether they found the information useful and whether they used it. And we were trying to find out about that, but I think it also served the purpose of them knowing we were following their use of it.
Right.
So we thought we might find a difference between trainees and experienced clinicians. That if I thought that trainees might not have as big a repertory of alternative things to do, and so the therapists might be able to use the alerts to more benefit to their clients than trainees. But that hasn't proved to be the case in any of our studies. It benefits both trainees and seasoned professionals equally well. And the only thing we've noticed is, with regards to training, is that the trainees get more red alert, so that patients have a tougher road to recovery if they see a trainee, and that it takes the trainees longer so that the patients are in treatment longer with the trainees. So they have more off-track cases, and they use up more sessions getting, but then they get the same benefit as licensed professionals.
Interesting.
So,
Okay.
so we don't know too much. We know one study we did with drug counselors in our drug and alcohol study, so these are not very well trained people. They got a benefit from the feedback just as much as our PhD level psychologists.
Okay, so I'm sorry to interrupt, but we need to wrap up now. It's time. Tim, just to answer your question, to add on a little bit to the discussion, I did a study on therapist characteristics myself in the interaction with feedback, and found that self-efficacy is a characteristic of the therapist that influences their effective use of the feedback. If you're interested, you can send me an email. I'll send you the link to the article.
Great, thanks.
Okay, so we need to wrap up now. Mike, thank you very much for your time and your wonderful presentation. I hope you enjoyed it. I know we certainly did. Can I tell people to send you their questions if they have some questions? There are still some people with questions, and we don't have time to answer them all right now.
Sure, I'd be happy to.
All right, thank you. So the webinars are going to take a summer break already, and after the summer we'll be back in September with Anne Doucette, who will be our next presenter. And from September on we will also start doing student webinars, which are given by students, for students, but also for senior SPR members. And Sam Norberg and I will be the first ones, sort of as a trial run, and from then on you can nominate yourself or one of your co-students to present. And we'll email you about that. So for now we'll hope to see you all, or as many of you as possible, at the SPR conference in Virginia Beach. And thank you all for attending.